when the patient first comes in, they're going to get a 2-page questionnaire, and that questionnaire is also available on our website, and that's just called the Breast Cancer or Breast Healthcare Risk Assessment. It really delves into, have you had prior breast biopsies? If so, what were the pathology results? Were they benign? Was it atypical? Was it malignant? And then it really, a whole page of the questionnaire is devoted to really your hereditary cancer in the family. And those would touch on really the hereditary cancers: prostate, breast, ovarian, endometrial, gastric, melanoma, colorectal, and a few others. All the information from the questionnaire is placed into a quick system by our techs where they enter all of it, and that comes up with your overall breast cancer risk score. We want that score to ideally, depending on age, be between 8, 10, 12%. 12.5% would be about average for the population as a whole. If that risk score goes over 20%, you're eligible for additional imaging studies like a breast MRI. You'd be considered high risk. Oftentimes a breast ultrasound would be added in that circumstance, including if you have dense breast tissue. It's a preventative versus a reactive approach. You know, do I want to be able to prevent something bad from happening based on the mutation I have, or do I want to react to, you know, a tumor that's developed, you know, because maybe I've ignored, you know, undergoing the testing, or I've declined it for, you know, several reasons. And, you know, and everybody falls in different buckets as far as what they have, but I've always thought of it as preventative versus reactive medicine. It's important information for other family members, you know. So we usually will kind of refer to a genetic counselor and then also say, hey, go back, you know, you've got to you look at mom and dad if they're still alive, which side of the family did this come from, and then siblings need to be counseled. So it kind of affects several family members. So it's, you know, it's kind of a downstream approach where we look at, you know, younger family members, including a lot of times, you know, these people say, hey, what should my children have done as well? And that's something kind of, once we find that initial pathogenic mutation that you know, kind of really saves lives at that point. So really, this is just a chamber that collects the patient's saliva, and enough DNA is in the saliva to be able to you know, get the, you know, genetic testing results back, whether they're positive or negative. And I don't know if we can see, but there's a fill line on the cylinder there, and you know, really they put some saliva into that, and this gets sent off. Usually we have results back in a week and a half, 2 weeks, and then we counsel the patient on those results, including, you know, if they're positive results, then we generally will you know, schedule them to go over those results. A separate report will go out to the referring physician, and then the correct referrals to other physicians will be made as well, including a certified genetic counselor to go over those results.